Here we present the case of a 63-year-old patient that underwent a retrosigmoid approach for a large petroclival meningioma. The residual tumor had been followed but is growing and compressing the brainstem with progressive swelling. We have described the different options for approaching this tumor, and this is the tumor location in the upper petroclival junction displacing trigeminal nerve laterally. We consider the combined transpetrosal approach to provide the best possible access for a complete tumor resection and to improve the dissection planes at the brainstem. We are now coagulating the middle meningeal artery, performing the peeling of the middle cranial fossa dura all the way back, and then now from posterior to anterior to expose the greater petrosal superficial nerve. We identify the tegmen tympani, the petrous apex. We continue dissecting the GSPN until we get into foramen ovale. We can see V3, which is now being peeled off the dura of the temporal lobe all the way back to Meckel's cave. It's important to carefully dissect GSPN from B3 to maximally expose the petrous apex. We can use electrical stimulation to confirm and Doppler to identify the location of the carotid artery at the foramen lacerum. This exposed anterior petrous apex, but now we're going to our mastoidectomy. Our neurotology team is going to perform this portion of the operation by drilling the semicircular canals. It's important to remember this patient had complete hearing loss from the previous operation, and therefore we are not aiming at hearing preservation here. This facilitates the exposure, coagulating the dura of the posterior fossa transmont triangle. We can see the semicircular canals which are being drilled. And we continue drilling the semicircular canals until we access the internal acoustic canal. We can see the posterior wall of the internal acoustic canal, now superior aspect. And now we're going to start removing the petrous apex anterior to the internal acoustic canal and above the internal acoustic canal. I'm going to take this drilling all the way anterior to include all Kawas's triangle, exposing the dura of the posterior fossa, using the ultrasonic aspirator to increase our exposure of the deepest portion of the petrous apex. We have now completed the anterior and posterior petrosectomies. We proceed with the dural opening starting below the tent, getting access directly to the attachment of the tumor at the petro-tentorial junction. We can start moving the calcified portion of the tumor, and we coagulate aggressively its attachment to the petrous bone. We stimulate finding facial nerve posteriorly, and we identify the posterior aspect of the tumor and the tentorium superiorly. Now we open the dura above the tentorium on the temporal lobe side. We identify a bridging vein that is running along the tent that we want to preserve. We are ligating the superior petrosal sinus, and we do this anterior to the draining point of this vein. We can carefully dissect this vein and transect the tentorium just in front of it to preserve its draining point. We continue cutting the tentorium all the way posteriorly until we find the tentorial incisura, where we are going to be very careful about the trochlear nerve. Just before doing the last cut, we need to stop and find the fourth nerve. That is the fourth nerve, which is attached to the upper surface of the tumor. And now we do our last cut of the tentorium. We can see the fibers of the trigeminal nerve severely compressed and stretched by the tumor. Now I'm going to proceed to just resect this portion of the tentorium. And as I do so, I can identify some tumor involvement. And now finding trigeminal nerve entering Meckel's cave, I just open Meckel's cave and remove some tumor from within. There is some tumor still inferior to Meckel's cave, but not superior. And this also allows me to mobilize trigeminal nerve more effectively, so I can work above and below the trigeminal nerve. And now identifying the medial plane of the tumor, now superomedial towards the brainstem. That's the fourth nerve superiorly. Now I'm coagulating the tumor surface and starting to do some debulking, developing further the dissection planes, and now getting into the central core of the tumor and detaching it from the petrous apex. I'm cutting the attachment and coagulating the attachment to the petrous apex. And this allows me to mobilize the tumor so I can find the medial aspect. We can start identifying the vascular artery medially and the surface of the clival bone. The tumor has been detached from the petrous apex almost completely. We are working now underneath 5. You can identify how we can alternate working corridors above and below trigeminal nerve. Now we can identify this beautiful interface between the tumor capsule and the brainstem. There is PL invasion as expected, given the T2 changes in the MRI. But this approach gives us excellent access to the brainstem interface. We identify an arterial branch, likely a superior cerebellar artery, which is being detached and preserved. And we can continue dissecting tumor and finding its interface with the surrounding structures. This is again the superior cerebellar artery being dissected and preserved. We can finally find the interface with the brainstem. As you see, this is not an easy plane of dissection, but the privileged view of the combined transpetrosal approach allows us to develop this excellent plane. Finally, the tumor has been detached and completely removed, and now we just need to look for the residual attachment of the tumor to the dura of the petroclival junction, which is transected and coagulated. We can see the surface of the clivus, the brainstem, and a complete tumor resection have been achieved. We can close the dura almost primarily. Then we use a vascularized pericranial flap that is pedicled posteriorly and a large fat graft for reconstruction. The post-op MRI shows complete tumor resection. The patient had a transient 6-nerve palsy that completely recovered and an excellent outcome. Thank you.